The other trial is Distal. Distal enrolled 543 patients, 271 to EVT and 272 medical management. Their inclusion criteria were non-dominant or co-dominant M2s, M3s, M4s, A1, A2, A3, P1, P2, P3. They included patients up to 24 hours from last known well, and the EVT arm included stent retriever plus aspiration in 65% of cases, and aspiration only in 16% of cases. And these are some baseline characteristics here. And again, most of these were M2 occlusions, about 40-50% were M2 occlusions. Median NIH stroke scale was 6 here. And also a little over 50% received IV thrombolysis. And again, it showed no significant difference in modified Rankin between the two groups. And here's a summary of the outcomes. The median modified Rankin was 2 in each group. There was no significant difference in excellent functional outcome or good functional outcome at 90 days between the two groups. And similarly, they looked at some quality of life scores, and similarly, these were not significantly different between the two groups. And death was also not significantly different between the two groups. As well as symptomatic hemorrhage, but these trended to be more frequently in patients who received EVT. And interaction analyses again showed no significant interaction in the subgroups, but you can see in patients who had a stroke scale above 9, perhaps these patients had potential for benefit, but this was not statistically significant. The other trial is Discount. It's not published yet, so this is the data I gathered from the International Stroke Conference presentation. So Discount was stopped early for safety concerns. It included 152 patients, 75 randomized to EVT, 75 to medical management. It included distal M2s, M3s, P1, P2, P3, A1, A2, A3. NIH stroke scale 5 or more, or significant aphasia within 8 hours from onset or less than 24 hours if no flare changes. And they use a stent retriever or an aspiration catheter. And as I said, this was stopped early due to increased complications in patients randomized to the EVT group. And this is from a summary from the AHA summarizing the trial results. So the primary outcome was more frequent in patients who received best medical management. So modified Rankin less than or equal to 2 at 3 months, 77% with BMT, 60% with in the EVT arm, and this was statistically significant. And there was twice as more symptomatic hemorrhages in the EVT arm compared to best medical management, but this was not statistically significant. So I'll stop here and send it back to Max and Eitan to open it up for discussion.
So is somebody going to this David, is somebody going to provide summary conclusions? Eitan, Max?
Well, like a summary of the 3 trials.
Yep, conclusion. Or do we have absolute conclusions here? Is this the end of the evidence?
I would send this question back, this comment back to Shadi to complete after his summary. Shadi.
Okay. Yeah, I can weigh in about what I think. I think certainly there's room for improvement in the trials. I think this is a starting point. It's not the end. We do see that some of these distal occlusions cause significant disability. So, I would say that we shouldn't really stop here. We should think about how can we help patients, maybe using different devices, maybe selecting patients with increased stroke severity, maybe focusing on, intraarterial lytics, or, focusing on patient selection, improved patient selection. So I don't think we should stop here. I think that this is a starting point to say, okay, how did the trials go? Why did they not work? And what can we do to better select patients and to better improve our technique. That's my opinion about it.
Shadi, can I make a comment on the discount? I just
Yes.
have two things to add. So in discount, we only selected very distal occlusion. So M2 above the mid-height of the insula. We did not include the proximal M2 like in escape MIVO and in distal. First, and second, there is a signal that maybe thrombectomy could be deleterious because it was 60% of good outcome in the mechanical thrombectomy group versus 77% in the best medical treatment group, but it was not statistically significant because it was an interim analysis and the cutoff for the p-value is 0.0002. So it's there is a trend. So we randomize in total 260 patients. So it was only the interim analysis on 163 first patients. We stopped the study and we will analyze the overall population, but maybe we will show that thrombectomy could be deleterious compared to best medical treatment alone.
Well, if I may comment on that, and can I share my screen?
Yes.
Because I actually have prepared a little bit of, I think that's a really interesting point, and we should, before we go on and compare, let me get this. Oh. You see my screen?
Yes.
So these were the segments in distal, and as Shadi said, we had a majority of M2s. But one thing that we have to take into consideration is that how we defined those M2s in distal. And so we try to define them from an interventionalist point of view. And I think we can all agree that treating this clot there is much easier than going around the corner and treating this clot there. So when you see that we have 40% if I go back, we have 40% of M2, 30% of M3. This means that these were really opercular occlusions, so around the insular curve and then going into the horizontal segment. As Frederic pointed out, it was a little bit of this different in MIVO. So this is from the MIVO presentation. As you can see, these were considered proximal M2s in MIVO. And then you have this segment there, which was the M2 for our trial, that was considered a distal M2. And one important point, if you see our supplement, you will see we had some M1 occlusions. Now the trial sites, they included M2s. They thought they were M2s, right? But then according to our methodology, the core lab went on and said, well, that's for me an M2 and for the trial an M1, sorry, because it was in this horizontal segment. So we have to take this into account. I'm not sure, this is the best way of describing. I mean, our way, maybe MIVO's way is the better way to describe it. But again, I think from the safety point of view and maybe also from the more homogeneous methodology, it helps to define those occlusions. Now, one thing that we try to use and our sites try to use is also the perfusion. So as you can see here, these are non-dominant occlusions, and we also had co-dominant occlusions, M2 occlusions. But they all had a perfusion deficit of under 90 cc's. So this was important also for our trial. And again, if you see the one or two M1s we had in the trial, they actually had big perfusion deficits and were also in the horizontal segment as opposed to the other trials. So again, what Frederic said, and I think that's more more to how we also described the occlusions. They went for the distal M2s. And again, we can see that a distal M2 in discount would be probably an M3 in escape MIVO. So I think we have to put all the images in the core lab and then speak with the same methodology.
Yeah, Mario says, this is David again, jumping in. I think he hit the nail on the point as well, Frederic, in terms of we're dealing with apples and oranges. The unfortunate aspect of this is that we have from the ISC and the press coming out with very definitive statements about conclusions being reached about what these entities are. First, nobody's mentioned this so far, but the concept of a medium vessel occlusion implies size. Size was not presented or detailed very well either. So I think there's agreement that these are all some form of more distal lesions, but the definitions are critical. Where because I think it's easy to say that we're not dealing with one disease state or condition of a DVO that we think is all the same across all the trials, and that makes it very, very difficult, as you pointed out. One other point on that is that people haven't focused on as much is, even aside from the definition in the different arms. The definitions were used based on CTA for the purpose of enrollment in a number of the studies, which is very different than what you see angiographically when you take the patient to the sleeve. Where you have much more detailed data. So it is a limitation. It's not easily overcome if you're randomizing patients. We're splitting patients into two arms.
Maybe I can make a comment on this. So just about the segmentation, when we use M1, M2, we refer to the article of Fisher from 1938. So normally M1 is a horizontal segment, M2 is a vertical segment along the insula. So if you use this segmentation, you have to be in line with this segmentation first. And second, in discount, we randomized 75% of the occlusion were on distal M2 or M3. So most of the occlusion were on the distal aspect of the MCA.
I don't know if you see my slide. I think you should.
It's a very good article.
There's a fantastic letter to the editor.
One of the best.
From Frederic and his group from many years ago, right? It's 8 years ago, and think about how
I was young and handsome at this time.
No, but to me is very, very important how like it was obvious that where we were going, and it was so obvious already at that time that this needed clarification, and it's incredible how much confusion there is about where M1 ends, where M2 starts, and I was surprised to find out, based on the Escape Mevo supplemental, that even the boundary between M2 and M3 is extremely confusing. And going back to what David said, like this is like I think we have to start by being at least on the same page about definition, and this is not rocket science. Trying to define, and we can decide either way. I think I think the distal and discount way of define M2 is make more sense than the Escape Mevo. But at least, how can we not be on the same page? So I think thank you, Marius, for bringing us up like a very important point. The problem is that even like in the trial that includes the most proximal, which should be like should bring to positive results, because we know that those are easier to recanalize and should be open. Even that one failed, right? And that's the bottom line. The bottom line that even Escape Mevo, which included the proximal M2s that we all do daily, and we all, as Frederic said, he didn't even include he tried really to be this much more distal, because it's obvious that those proximal two work in our daily practice. Even that trial failed. So how do we justify that? Like how is that our daily practice so different from the result of a randomized trial?
So Eitan and Max, congrats, because now we've really reached the BANANAZ qualification stage, where there's a lot of confusion, and it's gone a little bit bananas. But to throw one other element or variable in the mix, somebody should comment about this issue that now everybody's gone to dominance in a more proximal distal occlusion. And how do we define dominance? Because that's also been thrown out, but yet not measured in most of these studies. And is that a relevant variable? So I don't mean to add more confusion, but it's more food for thought.
Yeah. So thank you, David. This is the purpose of BANANAZ, right? To raise questions. The other question, like if we're gonna go down the road of that, of course, as we mentioned, a lot of these trials define it differently, but the outcome of the trial seems to be, negative for all of them. The other question is left versus right. At least for me, like if we're gonna talk about kind of scaling the stroke scale down to what are relevant deficits, I don't know if there's any of that information that exists in the sub-analyses. Another question that I'm not sure has been elucidated is to what extent in these trials are the lesions embolic versus not. If we talk about P2s, A2s, like I think in our experience, they're enriched in, ICAD. Has that been studied at all? Can that be studied in the trials, or what do we think about that?
Max, I suggest let's keep track of this concept. Mahesh was raised hand before you raised this
Okay, great.
concept. I suspect Mahesh wants to comment on the rest of the thing first.
Well, thank you, guys. And I just want to make a couple of points. One is, I think we all have to agree on a definition, right, of M2 versus M3. I personally like that the M3 is opercular and the M2 is vertical segment and M3 is opercular. So no matter how, and then if you want to make a distinction of proximal versus distal M2 based on where it is in that vertical segment, I think that's fine. But I don't think anything in that vertical segment we should call M3. I think we should reserve M3 for opercular segment branches. I just want to make a couple of other points, and that is that these trials were in a different era, right? So and Shadi knows this, when we were doing the earlier trials, especially like Diffuse 3, when there was still a lot of question, we would not and offer thrombectomy to somebody unless they were willing to go in the trial, right? So this was extremely a difficult thing to do, but what we did is we enriched for patients who were likely to benefit. I wonder how much of this is some of these trials there may have been some cherry picking in some of these M2s where you look at an M2, a proximal M2 with a big clinical deficit, and you say, gosh, I don't know if I want to randomize this patient. And maybe that these, a lot of us as experienced centers have a lot of experience saying, we should probably treat this patient. So that's one. And then I just want to respond to one comment in the chat. There was someone in the chat that talked about stent retrievers, and this is something we should get to at some point. So many of you know I'm a very big stent retriever fan for ICAs and proximal and mid M1s, but I tend to try aspiration first once you start getting into M2s, especially once you're more than a centimeter or so beyond the turn in the vertical segment. And I wonder if some of the increased hemorrhage rates had to do with that. But I'll just sort of throw those out there and see what you guys think.
No, I think the technique part, we're gonna get to it, and thanks again for raising that concept. We're gonna get to that. I think that's a very important one.
But Mahesh, if I could echo what you said, your first point, that was something I wanted to mention is, so we were part of Escape Mevo, and credit to Mayank and his team, they emphasized very early on that we want to make sure there is equipoise, and I have to tell you, for our side, it was extremely hard. And it wasn't even the neurointerventional team, it was the stroke team that felt extremely uncomfortable to refer to us patients with what would be an M2 definition by Escape Mevo and very severe deficits. I'm sure we've lost some patients with the most severe NIHs. And I think the equipoise was lost for, let's call it, sort of M2s at least. That's my personal opinion. I could be wrong. But we cherry picked the other way. We cherry picked the patients who probably were less likely to benefit. And the ones who were most likely to benefit, my argument is they were just treated outside of the trials.
So then the other point, Max, is how many of these patients, if you didn't have a trial, would you have offered thrombectomy for, right? And so Shadi knows this. So, we tend to be fairly conservative. I certainly don't offer by routine for opercular level M3s and beyond. So, you might say, oh, normally I wouldn't offer thrombectomy. But we have a trial, so we'll put the patient in the trial. So, maybe this is validating for some centers a behavior of patients whom they weren't going to treat anyway, they continue not to treat. I do worry, and we can talk about this later too, I worry that people will use this as an excuse to not treat some things that a lot of us would believe are very treatable occlusions, like Eitan was saying, an M2 that we treat every day in our practice. I do worry that there may be sort of a backlash the other way, where people say, oh, there's no data about distal, and I'm calling it distal, so I'm not going to treat that.
Yeah, and I think it might have backfired both ways. The patients you really wanted to treat, they were not a part of the trial. And as like you're saying, the patients that you're on the fence and maybe they shouldn't be treated to begin with, why don't we enroll them in the trial? And it doesn't really take too many of these patients to change the outcome, at least.
Just as a brief comment before we move on to other points, I think that is overwhelmingly a concern, Mahesh and Max. That the conclusions in the press in the broader general public is that it does not work. And this will be seen as, rather than indication expansion, this will be seen possibly falsely as indication contraction or a swipe at the market, whether right or not. So anyway, so I think it is a very real concern, and concerning because of what Mahesh you just pointed out in terms of the biases that may have gone in.
Marius, you raise your hand.
Yeah, great points. Well, one of the points that David made about, they were not quantified. We try to quantify this in our trial with perfusion. We have around 80% of perfusion in the patients that were included, and we're working on this right now. So I think this is going to be one way of trying to quantify, the deficit also from the brain volume point of view. And one thing we are seeing, just as an idea, is that if you have, I think our median is around 30 cc's of brain. If you have more than 30 cc's, you actually, with EVT, profit more. Just one idea. Then on the points that Max and Mahesh made, I totally agree. And I think the editorial of Jay in the New England was totally on point. Because as also they said, this is a double, not cherry picking, right? It is a double reverse cherry picking, actually. Because you don't treat those that you would treat and you should include in the trial, and you put in the trial those that probably don't profit. And actually, we saw that in the end of the trial that NIHSS started dropping and the age started raising. So people just decided, this is going to be a positive trial. We have to treat those patients outside of the trial. And so what we definitely need is I think a follow-up trial now that the sites that are in the trial, they commit that they will include every patient with those occlusions, right? We somehow have to get this to be done. And on the point of safety, I have some slides if you want me to show them, just as an idea. And I agree with Mahesh. For me, going to M2 to M3 with the new catheters that we have now, I think I do now aspiration first, and then I switch to stent retriever if that doesn't work. You're sharing, Eitan? Can I?
You should be able to share, Mario.
Yeah, you should be able.
Just start sharing.
Share.
And you can stop post sharing yours.
In a second. So as we were, approaching distal, one thing that helped us a lot was this meta-analysis that, they had
We don't see.
You don't see anything?
No, we do see.
I see it. I see it.
Oh, you do? Okay, sorry.
Only you, Eitan.
Only me. All right.
So again, going back to, planning the distal trial and, the Quattro technique, we were seeing this meta-analysis, and these are the data on the safety, on aspiration only, stent retriever only, and the combination, right? And to a lot of us, this was interesting to seeing the highest symptomatic hemorrhages on aspiration only. But I think probably this was device related, and people taking the 5 max and the Sophia, the big one, and whatever, the older aspiration catheters and going after a distal occlusion. Now, I have some data from the distal trial now, and as you can see, the worst group in our trial was the stent retriever only group. So again, this is first pass with this specific technique, right? So stent retriever only, and then people could switch. And of course, the numbers are low, but I think we see a tendency that, combination still good, but on the other side, we also see that aspiration is getting better, right?
That's very interesting.
And
Why do you think is the stent retriever with aspiration is so much lower subarachnoid? Very interesting.
well, I think I would ask, why is it so high, right? I mean, 20%
No,
of
no, no,
subarachnoidal with aspiration.
no. Take a look at the stent retriever with aspiration. It's around 12% as compared to stent retrieval only 30%.
You mean in the older
Yeah,
meta-analysis?
yeah.
I don't know, but
A huge
I've done a
difference.
lot of distal occlusions, and to be honest, this 30% is more than what we see actually, right? I think René Chapot also has published this a couple of years ago with 40%. I think realistically, if you count those flat panel CTs after your intervention as a subarachnoidal hemorrhage, and you see those frequently, it's around 20 to 30%. And so also this 20% here probably goes to, older aspiration devices in the distal trial. So we didn't have any case with the RED 43. And then people had to use, stent retriever as the second approach. And then you also have some more subarachnoidal hemorrhages. And again, we got those new aspiration catheters last year. And what we see now, I mean, this is something that we are preparing now to publish, is that we have much lower symptomatic hemorrhages and much lower subarachnoidal hemorrhages with the newer devices. I know these are retrospective data. It's nothing from a randomized trial. It's not core lab adjudicated. But still, this is also what I kind of see in my everyday praxis. I don't know what you guys think.
Marios, just one comment on that. This is David again. We have to be very careful again on definitions.
We cannot hear you well, David.
Ethan, can I just comment
go
about
ahead.
just about the potential selection bias of the patient? When you look at the average age of the patient in all the three trials, it's about 74 years compared to 65 in the pivotal study on LVO treated by thrombectomy.
Wait, repeat, Frederic, again, the age. David, hold on. Frederic is commenting, then we're going to get back to you. Frederic, you said...
I was saying that in the three trials focused on distal thrombectomy, the patients were older compared to the 5 pivotal studies in 2015. And
what's
the
the
NIH,
difference?
About 10 years in average, 74 versus 65. And the NIH was low. It was the median was 8 in discount. It was 6 in distal. So probably there was a selection bias, and the patient randomized were only all patients with a low NIH. And we saw that in my institution. When we wanted to randomize a patient, the neurologists were very reluctant because they were afraid that the patient would be randomized in the medical arm. They were super convinced more than us on the benefit of mechanical thrombectomy, even in very distal thrombectomy and very distal occlusions.
Shadi, I see you have your hand raised and you can unmute yourself. But what's before you comment, like what would be like the average NIHSS for an M2? Let's say an M2, right side or left side. What would be the average NIHSS?
I think it depends. Rarely you can see it above 10 if it's more proximal, but usually it's about 8, 9 average if it's on the left. On the right side, they tend to have lower NIHSS, around like 3, 4. But we have seen cases where they have severe deficits from a proximal M2.
So you're not surprised that distal trial NIHSS was had this median of like 6 or 8 or something like that. It's not surprising.
No, I'm not surprised because I think about 50% were M2s and the other 50% were very distal, and usually with those the stroke scale is lower generally. Okay. So no, I'm not surprised.
Okay.
May I just make a quick comment? And David had asked to say like a conclusion about the trials. I think the conclusion is clear there's no benefit, and there's a signal for harm. Now, again, as I said, I don't think this is the end. This is a starting point to make us think how can we do better and maybe selecting more patients. But the question I have is, we're speculating that people were treating outside the trial. Do we know that for sure? Can we go back to the sites and have them query and see how many patients who met the criteria for these trials were actually treated outside the trial? I don't know if we know that for sure. So I think it'll be a good exercise to do, and then try to think, okay, with perhaps stent retrievers, we can target more proximal M2s with severe deficits, and maybe those distal occlusions, if they didn't get thrombolysis and they have perfusion deficit, maybe we need to think of other techniques to try to recanalize them. And also, I'll just add one last thing. Recanalization rates were not great. And again, it's a testament to the techniques that we have are not really good for these, smaller occlusions.
One thing, about the cherry picking. I mean, it's not really like a guess. I mean, Max Mokin, it was part of it, and he just admitted that there was cherry picking in his place. Anybody else was part of Escape Mevo here and want to tell us if that was the case as well? Like, please raise your hand and let's discuss. But Shadi, he was part of the trial. So, is it really an assumption or it's a truth, right?
No, understood. But I think we have to understand, why did people cherry pick and who was cherry picked. I think that's the first step, to try to understand who we need to select for future trials.
But Shadi, in addition to the cherry picking on the patients that we normally would have treated, I think Max made another good point, which is, so a lot of these were patients that we would never have offered treatment to. But because there was a trial, we put them in the trial. So if the patient walked in and there's no trial, we'd say, it's kind of distal, stroke scale's kind of low, probably no benefit. They already got TNK. And we wouldn't have offered thrombectomy, right? So you're taking patients that and so I think this is one way that I interpret the results is, most of the patients that we had been saying no to ahead of time, we probably can continue saying no to until we come up with a better trial.
Yeah, no, I am in total agreement. But I do think that the trials was targeting these patients, and that's why they included them. And I think the trial answered the question that we probably should leave these patients alone until we come up with a better technique.
Now, anybody wants to comment more on these concepts?
Just one comment. In discount, we collected all the patients who were screened but not randomized. So we will have this information of the amount of patients potentially treated outside the trial.
That's a great thing, Frederic. We did not include that in Distal, so we don't have screening logs. One thing that we could do is to take the Swiss stroke registry and see in this time frame that we run the trial in all the Swiss centers, how many distal occlusions were treated, and have a signal of how many were not included. Although it's not easy, I think, because if a patient comes at 12 o'clock in the night, you cannot force somebody to randomize that, right? We tried this in Basel, but I think it's not easy in all sites.
Vladimir has a hand up. Unmute yourself.
Yeah, thanks. The fact is about the technique. Yeah, the technique is changing, and Marius just sublined the fact, the new catheters and everything. But if you approach a distal occlusion, the length of the stent retriever, the radial force of the stent retriever, the kind of stent retriever can influence a lot on the result. So if we are speaking about the technique, we should maybe initially make a definition of the appropriate technique for the distal treatment. We are picking a very different areas to treat, very different angles, diameters of the vessels to treat, and at the end we are trying to get homogenic results. I'm not so sure that with this kind of so many variables, we can get the homogeneous conclusion?
I think it is time to move to the technical aspect of this, and I'm sharing here the screen of the discount just because I had this slide ready, and I don't know if you see it, but Frederic, is your slide, obviously. And we mentioned it already, and I think that's another paramount thing. So we went through like the definition, how being on the same page of the definition seems such an obvious thing, but we're not, right? And like the obviously the cherry picking, and this technical aspect is a very important one. In Escape Mevo, 100% of the patients were done with stent retriever first. In Distal, 80% had a stent retriever placed, used as a first as the technique. And Frederic, in yours, what were the rate of stent retriever?
It was about 23% for 3 max and the rest for stent retriever.
Okay, so 23%, like an old generation aspiration catheter that last time I used, by the way, it was probably like 4 or 5 years ago, honestly. And like, in I don't know if we were lucky in the US to have newer catheters, among which the Red 43 already for a few years, but the 3 Max, it doesn't exist anymore, even in our shelf, just to be on the same page. So essentially, like, it's obvious that, the technical aspect here is very important. In all the 3 trials, the technique used was sort of like not at least in what would be the most modern approach in our place. Any comment? I mean, we kind of touch upon this, but like, what do you guys wanna add?
We didn't use the Red 43 because at this time it was not available in France. We have it since
No,
1 or 2 years.
Listen,
So
it's not
for us.
Mine is not a criticism on the trial. It's just like
No, but just to explain.
a critical review of like why trying to understand why like we end up with results which are like a little different than what it seems to be like a lot of people experience. Vladimir.
That's a rerun. That's a rerun of the trials of the very first trials, right? It's a real rerun. That's exactly what happened back then with the first two stroke trials, thrombectomy trials, that they used different tools, obviously, all the tools. And also one more thing.
Not only the tools, I think it's also about the training. We have to address this also at some point, and we are looking right now if there was a learning curve in the trial for our trial. Frederic, maybe we can join forces to study that because I've checked every angio a couple of times now, and in some sites I have this gut feeling that the first case was not so good, and then towards the end it's getting better. So of course this is also a point.
The fact is, like Aidan, just like you said before about the techniques, and you showed that slide about 3 max, 4 max, 5. Those are the catheters that we nowadays don't use anymore, but now we have the results of the studies. So we are now in a situation that we can for sure give completely different technical approach with aspiration catheters. Maybe not that much with the stent retrievers, but with aspiration catheters for sure.
Okay, but I guess to get back to Eitan's question, the big question is, how much do we think this plays a role? Like, we have better devices, better Tickies. Can we comment about like what we think, how much differences is going to make?
So what were the Ticky scores in the 3 trials? Let's just to summarize. Like Mario,
but Eitan,
they were actually
this is something that you cannot compare to the usual retrospective stuff you get, and that's why I made the comment about our red paper. This is retrospective. You don't have there the patients that probably were recanalized from the CT in the angio, right? You have those in a randomized trial. There are some stuff that are different where you're comparing the data we have now, and for example, in our trial, the 70% is coming from the denominator, every patient that went to the angio. If you take only the patients that actually had an EVT, it's 80%. So I think we have to be cautious with, comparing the two things.
Yeah, Mario. So just
David, we cannot hear you. You're breaking up. Marios, what was the Ticky, let's say, to be
overall,
in
but they're not. No, in general. I mean, if you look at escape mevo, but it depends on how they were defined. They were defined based on both arms.
David,
as well.
You're breaking
so
up.
the numbers don't. The numbers don't add up as well. So it's a very difficult comparison because of the points that Marios mentioned. The denominator, who are you including? How is it being measured? Are you comparing to the baseline CTA? Very, very different measures. But overall, the numbers look bad, but they're bad because of how you're looking at those specific subgroups in terms of revascularization, reperfusion rates.
Just to comment, in discount, the recanalization rate, so MTK 2B or more, was 77%.
Marios, what was it in distal?
71, but again, it's regarding the denominator. So we went for a angiographic result. So we only wanted to have the result of your intervention, your EVT treatment. And so what that means is that if the patient had a recanalization from CT to angio, we excluded this patient from the Ticky evaluations. We then defined it again. You can see this in our supplement as a new occlusion. So if the M2 then was an M3, then you can see the results for this M3. And if you did not have a recanalization of the M3, then it was a Ticky 0 in the end, just to be clear.
Okay. And in escape mevo, max smoking, what was the Ticky 2B3?
Oh, you got me. I would have to double check right away.
I think it
It's
was
78%, I think, right?
No, 74.
So it's interesting that the number is extremely similar among 3 trials done in 3.
Am I the only one who thinks that Ticky is not the best scale here to begin with?
Well, it depends how it's done.
It is.
There's so much confusion about it.
Right.
What
But again, but Eitan, I agree with you, Max. It's not a question of the scale. It's a question of how the scale is applied. So in sum, once again, if you look, 71, 74, 77%, 2B to 3 is horrific for endovascular therapy nowadays. This is horrible. This is not the standard for endovascular therapy in general. 2B, meaning 50% or greater reperfusion of the territory in more proximal occlusion. 5% in trials and in practice. When you wind up with 71, 74, 77%, this is very, very low. But it all depends on how it was applied. So it's not a question of the problem of the scale and defining a new scale to match the specific scenario. It's a question of how it was applied.
Yeah, I mean, my understanding, for example, escape mevo, and Shadi is saying that you're starting with 2B. No, because the escape mevo made it started with a Ticky 0 because it evaluated the percent of revascularization of the initial occluded territory. That was my understanding, Max, about the way that the Ticky score was applied.
But what you just described is such a common misconception. People are so confused about what do you start with to begin with. So it's not that Ticky is bad. It's hard to interpret it, right, for distals. And so perhaps we have to have something different, something.
Well, maybe we need a D-Ticky. Maybe we need a distal Ticky score because Ticky works really well for M1 occlusions, but it's very hard to scale across people for anything outside of an M1 occlusion.
But hold on. Let's take a step back.
Guys, I'm not sure.
The way the Ticky score was applied for at least for escape mevo,
it's a 0 relative to the territory, right?
Yes.
So
exactly.
So you don't start at 2B. You start at 0.
You start 0.
0 relative to the territory subtended by that branch.
How much territory you open?
Yes, everyone is on the same page, but just look at Twitter or X and see how many people are calling a baseline occlusion as a 2B.
That's a different story.
But that's us. Right. That's neurointervention at large.
Well, Max, I mean,
David, we can really you're breaking up a lot.
So as David is breaking up, again, we also took the Mivo Ticky, right? They have published this. Mayang has done a great job, and Johanna Ospel. And you actually take the initial occluded territory, right? The vessel that provides the perfusion to the missing territory, and you compare your final to this initial. You don't take the whole M1 MCA territory like in the M Ticky, right? So if you want to call it a D Ticky, it's okay. But in the end, it's the same thing. You're comparing perfusion deficits on the lateral image and the final result you have. So I think
Wait.
it's an easy score to do, actually.
Yes, but so
Marios, just a comment there. I hope you can hear me. Can you hear me?
Yes, now yes.
All right, perfect. I thought I was being canceled or muted. That is and is not true. Johanna and Mayang's paper on Ticky and distal occlusion actually said the opposite. The graphic shows beautifully how you should not be doing it. You should develop a separate scale, which I disagree with. You have to, but I agree with you, Marios, that you should be doing it based on your angiographic occlusion at baseline before you start the procedure. The comment that I think people are glossing over, it's not a question, again, about the scale. It's how the scale is applied. And when you're using non-invasive imaging as a comparison for what you get in the angio suite, we've written on the cross-sectional Ticky for thrombolytics that are used. There's a difference in terms of how the Ticky is applied. So anyway, it is complicated. I think the tools exist, but you have to be careful in terms of how they're applied.
I mean,
I'm searching for our Ticky definition, and then you can visually see what I described. Give me a couple of minutes. I find it.
I mean, the Distals trial, which is still ongoing, looks at the perfusion, right? 1 day after, right? If I'm not wrong,
it will look at both. It looks at perfusion. It also looks at your Tickies.
So even with the outcome definition, like we see how, and if you look at the comments, you see how much confusion there is. So confusion in definition, confusion in at least among the public, maybe among the trialists, there was not much confusion, but among the recipients of these, as Max pointed out, there is a lot of confusion. If
we
there's
can
no
certainly say we can certainly say that the number of complete revascularizations can be improved. Like that is like we can probably all agree on that. Now, is Erez enough? So speaking of distals, maybe this is a time to speak a little bit about distals because that's one ongoing trials.
Can I share my screen?
Yes, please. Go ahead. You should be able to share.
Sharing?
Yep,
can you see my screen?
Yes.
Okay, so I'm the local PI for Distals at NYU, and yes, there is still hope. We still have this trial, and it's a very important trial. I'm going to talk a little bit about the trial, a little bit about the differences, and a little bit about Tiger 13. So first of all, the main important features of this Distals trial is that, first of all, it's the first FDA-approved medium vessel occlusion study with independent imaging core lab, obviously. It is an imaging-based primary endpoint as compared to a functional neurological endpoint that had in the other trials. That is a very important part of this trial, hypoperfusion improvement in the affected tissue that we are treating. The third point is that the Tiger 13 is actually the only stent retriever that is specifically designed to treat distal, medium, and distal occlusions. It's controllable, it's flexible. I'm not going to talk a lot about the device itself, just about the trial. And lastly, it's a mechanical thrombectomy is the only treatment modality that is under test. And for example, patients that are receiving TPA are not included in this trial, which is a completely different story than the other trials. So Tiger 13, like just a single slide, it says a minimal delivery forces because you can deliver it while it's completely collapsed. For the people that don't know Tiger 13 here, it is better. It's much lower force when you deliver it as compared to other stents that are usually treated in distal vessels. There's active integration. You can open and close it inside the clot. And when you retrieve it, there's also minimal retrieval forces, and you can see them again as compared to the other stents that are being used in distal vessels. It's less of a force when you pull it on the way back. The endpoints are really important because they're really different than the other trials. First of all, there's successful reperfusion based on CTP or MR perfusion without, obviously, symptomatic ICH. Two additional important features of these trials are in the secondary effectiveness. And we will measure delta NIHSS, which was not measured, I think, in the other trials. And we also look into cognitive function tests based on the MoCA assessment, which was also not assessed in the previous trials. In terms of the inclusion criteria, I just want to make an important, only the yellow things are the most important thing. NIHSS, as you can see here, between 4 to 24 or 2. If there's aphasia, we need a perfusion lesion. That's a major part of this trial. And the last thing is that, as I said before, patients that are receiving TPA are not included in this trial. And exclusion, kind of similar to other trials, secondary distal occlusion are not included. Tandem occlusion, these are patients are excluded. And patients that are treated with oral anticoagulation within 48 hours are also excluded. So the idea is really to test the device itself. And this is the most important feature, I think, of this trial. In terms of what do we have until today, there are 22 active sites. 84 subjects has been already enrolled and randomized, and we still need 34 to get into the final line of this trial. In respect to these 3 trials that Shadi and everyone discussed now, what's important here to see, I think the most important thing, first of all, it's all post-market registries, right? Which obviously have selection bias as people were talking about before. Most of them, or almost all of them, were treated with the first generation stent retrievers or aspiration. They did use Tiger 13 in 12 cases. I think that you showed Eitan the discount devices. The Tiger 13 was approved for this trial, Frederic, right? But no one used it. Is it correct? I think so. There was no treatment.
It was authorized, but I think nobody used it, yes.
Yeah.
Right, but Erez, just as a point, 12 out of the denominator. So it's a very, very small percentage.
Correct. Yeah.
I think it was 2% overall.
Yeah, and very important to see the differences between these trials and the Tiger is that the outcome, right? They were all looking on the outcome, which is MRS, and the problem, obviously, with MRS, we all aware, most of us are understand the problematic issue with MRS in distal trials or in distal vessels. And just take a look at the third row here. This is a very important feature. In distal, 60% were admitted with great MRS to begin with. So how do you follow these patients? And the outcome in MRS, it's too crude. It's not so good for distal assessments. So this is from the trial. And when we compare them, the first 3 trials, all self-expandable stent retrievers or aspirations, this is a small radially assisted stent retriever for distals. We spoke about the equipoise, and it's a great issue, right? Now we're at equipoise again. So the first 3 trials, the entire trials was biased, and now at least in distals, at least the last third of the patient, if we look at this 30 patients, maybe we have better, and maybe we'll be less biased, maybe. I'm not sure, but maybe. No TPA in distals, as I said before. There's a need to show that there's penumbra to begin with in distals, and MRS, as we discussed before, which in distals we are looking into MoCA and into NHSS at 90 degrees. This is just a case, one case from the trial that showed the issue, the main issue. This is a right P2 occlusion. Patient had NIHSS of 5 when he arrived. They did do 3 passes, managed to get Ticky 3, discuss the Ticky issues. No any symptomatic hemorrhages or even any other. And the outcome was MRS still a 2, begins at 2 and now 2, and now the NHSS is 2. This is kind of the summary. So as compared 5 to 2, I would prefer NIHSS of 2 for myself in this specific case as compared to 5. These are important features of major neurological issues, and I think it's a better assessment for these distals.
And it's not so much just focus on distals, but you bring up an important point that we haven't stressed enough, which is I think this is proven once and for all that the modified Rankin score at day 90 is almost completely irrelevant in this disease state. It is, you cannot have efficacy, a clinical efficacy, an improvement in such a setting, and it's a very crude measure, as you point out. It does not deal with eloquence of one distal vessel occlusion versus another. I think it's time to throw out the modified Rankin score at day 90. There was a very interesting paper from very old data from the Hermé group that Joanna published 2 days ago or 3 days ago, looking at 24-hour NIH stroke scale score compared to 90-day modified Rankin in obviously proximal large vessel occlusion, demonstrating that deficit scores such as the NIH actually are very useful in terms of looking at efficacy of thrombectomy. So I think there's going to be a shift, whether liked or not by FDA, to move away from the modified Rankin score. I think we're at the end of the argument with any permutation of the modified Rankin score. It's really not applicable. You know, the downside, the flip side or counterpoint to that is that when distals is done, that should be done, you know, this year, everybody's going to turn around and say, but there's no clinical. You know, you didn't prove a clinical benefit because that's not what you looked at. You looked only at the imaging outcomes. But I think it's an open question as to, we have to ask, what should we be looking at?
But that would be the starting point. That's what I absolutely agree with you. But that would be the starting point. From there, we can say, maybe, hopefully, yes, we are safe with this device.
Well,
and now
I don't know.
I disagree with you because for me, the main endpoint is clinical endpoint to recognize a vessel. If the patient does not improve, it's useless. And so I agree that the MRS maybe is not the best scale to evaluate improvement of the patient, but just angiographic or perfusion primary endpoint for me is not relevant. And the other point is, if you include only patient who did not receive IV thrombolysis, you will reduce the scope of patient who can be treated, because in discount, and I think it was the same in distal, 70% of the patient received IV thrombolysis. So I think we should not remove this patient from this.
But maybe this will tell us that those are the patients that we have to consider to do thrombectomy, right? Assuming, and I think it's a very strong assumption this trial will be positive, because, you know, given what we went through now, like, I'm going to assume that this is going to be negative, but let's say it's positive. Okay, then at least you know that subgroup, like, you know, maybe...
When you look at topmost, you know, it's not a randomized trial; it's a registry, but comparing best medical treatment versus best medical treatment plus thrombectomy only for PCA occlusion. There is no difference between the subgroup in terms of clinical outcome. But when you look at subgroup analysis, the only patient who benefit from thrombectomy are patients who cannot receive thrombolysis and/or patient with a high NIH score 10 or more. So maybe only this patient will benefit from distal thrombectomy.
Marius, you wanted to share the Ticky score, taking a little step back with that discussion. You found the slide.
Yes, I found the slide, but let me first comment on the Tiger. I think it's a great device if you're going after those really, really distal occlusions. We use it also. And one thing I would recommend for the beginners of using those devices, deflate it before you retrieve the whole thing. I think that's my point. Regarding the Tiki, I think it makes this clear. This is not your typical M1 MTiki, right? This is how we are going, and maybe we should call this the DTiki, as somebody proposed. But you can see this is your initial deficit, right, in this occlusion, and this is your final angio image. So this is a Tiki 0 in our trial. Let's go for a Tiki 2B. This is the initial deficit, right? You can define it on your baseline angio. And then finally, you have a reperfusion here in this red territory. There is still one branch missing here. So this is a 2B. And then you go, okay, show me a 2C example. You can see it here, initial deficit. Most of it gets reperfused. This is a small area here. So this is the 2C. And then finally, the Tiki 3. As you can see here, this is the full recanalization. Going back to my point, and sorry, but I have to go after that, of the Tiger 13. These are some cases of an M4 in distal, right? And you can see this is not the final angio. This is the baseline angiogram showing the deficit, as we discussed now. So this was the deficit for this M4 inclusion. You can see here, this first one was treated in Basel for me with a Tiger 13, actually. And you can see also the other cases. So not a lot of cases, but still you can see that we are talking about really, really, really small deficits with those occlusions.
Excellent, thank you.
Shadi is still with us?
Yes, I'm here.
Marius, thank you. If you have to go, thank you for being here. And you can, like, we'll send you the questions later. Okay.
Thank you so much.
Thank you, Marius.
Shadi, I wanted to hear your opinion about this MRS in these trials. What's your feeling about it?
Yeah, no, I echo what David said, and everyone else. MRS is not really a good tool to look at people with distal occlusions, especially those with mild deficits. I think Distal did a really great job looking at other quality of life measures. So I think we should consider looking at those as well, maybe as a co-primary outcome. If the FDA requires using the MRS, but at least escalating those outcomes and capturing them in MEVO and DEVO trials, because patients can still be pretty disabled and their MRS is 1 or 2.
Thanks.
There's a comment in the comment section about lytics for IA. Let's talk a little bit about that.
Can I
that's the future?
Sorry.
Yeah, go ahead.
I was just going to say, we have to be careful about, extrapolating the positive intraarterial lytic trials. Those were in patients with proximal occlusions who received EVT. So these do not apply for distal occlusions. We just have to be careful. Maybe this is the avenue to explore, but I would be very cautious, changing the practice where we're starting to, do IA-TPA, especially that endovascular treatment, at least with stent retrievers and aspiration catheters that were used in the trial, show the increased signal for symptomatic hemorrhage. So we certainly don't want to add.
Shadi, I would underscore that tremendously, Shadi. We can't transgress on the data and just jump and say, well, a lytic can be used. If everybody's not aware of this, everybody listened to these presentations at ISC, and everybody that has a different product or approach, drugs, nanoparticles, different devices, different aspiration devices, everybody thinks they know better now about distal vessel occlusions. And I think we have to be very careful because, as Eitan, you pointed out, and Max, you pointed out, this group itself is a little confused as to what we studied here. So that anybody that comes along and says, now I have a better idea, well, everybody thinks they have a better idea. They have to prove it. Sorry.
Excellent. Now, I suggest to go back to two specific situation and points that Max raised earlier. One is the side, right? Right versus left. Frederic, Marius may listen to us if he wants to interject, but Max Mokin, do we have any data on these trials about right versus left? Or did we make sure that they were weighted among the two groups? Go ahead.
Well, so I believe there was no signal. You're talking about dominance essentially, right versus left.
Yes.
And it is, I would argue, it's nearly impossible to evaluate dominance in a setting of acute ischemic stroke. I think David, we had a discussion on this before. If you could weigh in, but I mean, I think the bottom line is right now there is no signal, but this should not be. I don't see this being a valuable
But did
metric
we
going
make sure
forward.
at least? Did we make sure at least that there was the same proportion of right versus left in both groups, like
Right.
control versus EBT?
I mean, right and left versus dominance of a particular vessel segment. There are two different things. Obviously right-left differences, Eitan, as differences in terms of stroke severity, in terms of the nature of the deficit, as well as in terms of the outcome measures as it's measured in various ways. So there's that difference of right versus left, which is just as different as an M2 versus a P1. Or proximal or distal. So again, very, very different lesions that we're dealing with. When it comes to the dominance, Max, I can comment. Nobody has measured dominance. Nobody knows how to measure dominance. There is a very effective way of measuring dominance, but nobody's going to do this acutely. So my issue with dominance right now is that everybody's jumped to this based on the trials that have been done, saying, oh, maybe we should go after the dominance, angiographic dominance, the dominance of that M2. And although it's been proposed, it's not been actually applied to practice or measured and proven. So I would be very careful about that in terms of when anybody says, oh, that was a dominant M2 or not.
Is that captured in the weighting of the NIH, the presentation NIH
No.
stroke scale? Or, I mean, because
No.
Fronto-opercular branch on the dominant side is different than a fronto-opercular occlusion on the non-dominant side.
No,
so it
no,
may
I'm
be
not.
captured in your MRS NIH scales.
Possibly, but that's a different definition of dominance in my books. Dominance angiographically means that when you have a bifurcation, that what you're dealing with
there
is
are two different concepts of dominance, like
right.
hemispheric dominance versus angiographic vessel dominance. So I think the vessel dominance we discussed a little earlier. How about really like the right versus left? Let's say, let's be a devil's advocate, right? I'm saying, in escape MIVO, like all the left hemisphere went to thrombectomy, and all the right hemisphere went to conservative management, right? It's obvious that the right side did better than the left. If I'm a devil's advocate like this, can you prove me with data that was not the case? I'm talking about escape MIVO. How about the other trial?
We will try to prove you, but I think that that's not the case because the right side is going to have a lower NHSS for the same occlusion. So if you have the NHSS as your inclusion criterion, you will have on the right side probably bigger vessels. That's what I understand.
Okay, that's a good point. But there was no like the two subgroups were not weighted for right versus left. The two,
right, but I mean, if going to Mario's, agreed. Going to Marios's point, using the NIH stroke scale score as a deficit score is a very good thing to do in terms of comparing right versus left, and also as a move away from the modified Rankin score. So it's a measure of the acute deficit and the impact in terms of what you do with any therapeutic intervention. So I think going after the NIH stroke scale score and using that to equilibrate or standardize things is a good path.
Okay. Any other comment on this? Otherwise, there was another issue that Max.
Hey, it's Karthik. So, David, I think Eitan's point needs to be emphasized much more. I mean, as we get further and further into these deficits become more and more sophisticated. and they're not going to be measured by the crude tools that we use. So it's very important to separate right versus left. And if we can do it, it's easy to separate right versus left, much easier than angiographic dominance, etc. Right versus left is very easy, and I think they should be a fundamental part of any sophisticated trial. And maybe small errors add up, and eventually, you're left scratching your head as to why you think it works in real life and not in the trial. But anyway, I'm saying that there could be such differences that the right versus left is a very fundamental difference that needs to be captured in any sort of sophisticated syndrome that you're chasing neurologically.
Frederic, do you want to add anything on this?
Yeah, I agree. I just one comment, but for Frederic comments, I agree completely. There's no rationale as to why it shouldn't be analyzed.
Can we have it analyzed? Is it possible, maybe either for next bananas or before, to have this like somehow pushed out into the community?
I don't have the data for discount because we only perform the interim analysis, but there was a stratification for the randomization on the NIH. So the NIH score, as you said, can capture, the dominance. So, but I don't have the numbers yet.
Okay, the other point that Max raised earlier is about other disease. So, just honestly, just as an example, I'm sharing you a case, right? And let me share. Is not this one. Sorry, this one here. Just for the purpose of discussion, 69-year-old, last on well 7 hours before, NHSS of 16 actually, and you see there's an M2 occlusion, and this would have been a case that we probably would have potentially been included. Maybe not because it was one of those cherry picking, but on first angiography, it becomes obvious that when you look at these sort of like small, tiny collaterals, comes pretty obvious that probably we're dealing with something else than an embolus, right? And indeed, after recanalization, now we have...
so would you have randomized this patient or just treated it?
Probably I would have treated, but it would have been included in the trial. Well, I was not part of any,
But had you been?
Probably yes. I would have included in distal if there was other exclusion criteria here. But yes, why not? But whatever. This is the point we discussed earlier about the cherry picking, right? Here, I'm raising another problem, which is after recanalization, you see now there is a stent river open because there's an underlying disease. This is obviously ICAD, and here we ended up like stenting this. But this is just an example case to discuss this idea, like how about the underlying disease? Is it something that, ICAD essentially? Is it something that the trials found? Is this an often like a frequent problem enough that could have sort of like, become a problem in the analysis and in the interpretation?
So, Eitan, just commenting on that, ICAD gets ignored in general. Nobody wants to recognize ICAD in more proximal vessel segments. So was it ignored in more distal segments? Guaranteed. I think everybody makes the assumption of whatever is more distal is going to be embolic. Is it a question, and how many patients did it affect that were actually enrolled or not enrolled? Unclear, complete unknown. But I don't know that it's that easily solvable.
David, it's not easily solvable, but I can tell you again from reviewing the distal images that it's not so uncommon for the A2s and the P2s that we treated and included in the trial.
The proportion of patients with...
Wait, Marios, just on that point, P1 disease accounts for 1/3 of all ICAD in China, in Asia. So if you want to include P1, you're definitely dealing with ICAD there. I agree with you that I don't know how to solve this in terms of prospective evaluation of any given.
Frederic, you want to comment on this?
Yeah. In this count, underlying ICAD was not an exclusion criteria, but I have only the cases we did in my institution, but we had a couple of ICAD, but not so much, and we had a rupture of the parent artery for a P1 occlusion during the retrieval of the stent retriever. So maybe they are more risky to treat compared to embolic occlusion. And there is a oriental MIVO which is ongoing, which is the same design but in China. So maybe we will have more ICAD in this Asian population.
The problem is that it's hard to predict based only in the CTA. Sometimes but very often you cannot predict. So you may include without knowing.
Yeah, I agree.
Sometimes you have other
stenosis.
Sorry, if you look at the number of patients with known atrial fibrillation, for example, in the large trial, like more proximal trials and these trials, I think, you know the number, I think it's about 30%. Like, so maybe that could be part of the signal of like how many of these patients are embolic. There's less people with AFib in these trials than in the previous ones.
Max, that doesn't work well. The concomitant AF. So I'd be careful about that. It's approximation, but it's approximation.
Hard to hear, but you're skeptical that it's a good marker.
Sorry, there was João Andrea. You raise your hand and I go ahead and unmute yourself and talk. Sorry,
Okay, this is. People said, let's just go.
All right, so there's someone we need to unmute.
Yeah, we did. I got it.
João Andrea.
No, it was a mistake. Sorry.
Oh, okay. All right, no worries.
But I think the issue of how to figure out how many of these lesions were not embolic necessarily is it's hard to deal with, right? Like, how do we, if we strive for a Ticky 3 or whatever we want to call it, then we're going into the land of like, how do we open these things, right? Yeah. Do we stent them? Do we not? Like, it becomes the antiplatelets. It becomes very difficult.
I think we're all agreeing these are more challenging lesions to treat, no matter how we look at them.
What about guys, Eitan, and about pre-angiogram assessment, better assessment of ICAD, distal ICAD? Is that in the near future, or you feel that that's where we are?
I think it's hard to distinguish on cross-sectional. I mean, sometimes you may suspect.
I understand that today, and I see that, and obviously, but what do you think about the future of?
I think maybe if you do MRI, there is maybe with MRIs, but in Europe where they have more MRI experience acutely, maybe they're doing something. For us, I think moving to MRI at this stage is going to be very hard in the acute setting.
In the chat, Simon makes a point of like analyzing if a clot was actually retrieved, a thromboembolus or not, which is frequently not the case with ICAD, that we don't retrieve anything.
That doesn't work either. I mean, in terms of what you happen to get or not happen to get, that may or may not work. So I'm sorry to be pessimistic about this, but Eitan or whoever is suggesting this, is it possible in the future that we're going to be looking at endovascular assessment for ICAD? I'm very pessimistic about that. I was going to say, Eitan, I was going to rib you and say, between stenting M2s and suggesting MRI and acute stroke, you're really going bananas.
Shadi, go ahead.
Yeah, I was just going to say, there are some clues that indicate ICAD, but they're not 100%. The perfusion pattern is one, if you get a perfusion. The other one is, often we see these occlusions to be kind of like pointy. They're not just, you can often see a thrombus on the CT or an abrupt occlusion in non-ICAD LVOs, but in ICAD LVOs, they tend to kind of taper off and be a pointy occlusion. But I don't think these are 100%, and I think having more reliable tools initially could be helpful with patient selection.
So proximally, you can use OCT or IVUS or some sort of technology like that for intraoperative determination of ICAD. Distally, I don't know. I mean, when we say the future, intraoperatively, distally, maybe OCT or ICAD after your first pass will tell you what's wrong. OCT or IVUS, I mean.
All right. Next, Vladimir, do you have your cases ready?
Yeah, I have cases ready for sure.
And then after you, there's gonna be Raj Kamal. Are you connected?
Okay.
Raj Kamal Kangura. All right.
Do you see my screen?
Yeah. Now, after you can focus on the things based on the discussion also. But yes, we see your screen. Yeah.
Okay, perfect. So what's the fact? Ethan, just after the idea of the results that came back, so I was in Angio working with my colleague, and my colleague neurologist said, "Oh, you saw that the distal doesn't work," and this is the reason why I asked you for this opportunity to discuss, and I'm very happy because there is a lot of confusion, and with the top players in the world, we made all this mess about no conclusion about the distals and a lot of variables. I distals see just like this. So this is the paper that I used, you guys, that you published, and in these six images, you see just the 6 different of risk of treatment of these vessels. So the fact is like, if the vessel is occluded, how can I know the anatomy after the clot? How can we choose the right strategy for the treatment, meaning the right technique? We are guessing based on our experience, knowledge, and the technology of the moment, that the fact like the catheters that have been used for these treatments, we don't actually, in my practice, I don't use them anymore. If we go back in 2021, this is the situation which I want to share with you. This is the residual clot in the front opercular area that I've been using the catheter that was in that study, but also in unsubtracted angiography distally, you can see the clot. The clot is inside of the whole vessel. So this was the residual of the proximal occlusion. Treat or not, how to treat it. And I've done it with 3-max catheter. So the 3-max catheter is deployed distally over this is Chikai black guide wire. And the fact is like, I want to show this. This is the aspiration for Vaclock syringe. And you see that I'm pulling back the catheter. My vessel is coming back and it's following the catheter. There is no aspiration inside of the catheter. And I'm pulling, hoping that the vessel will get back at some point. When is the point? This is the point when it gets back. So this is the aspiration for 60 milliliter aspiration syringe. So this is the control, and you see the mass. And the fact is, like also Mario said, you see the time, this is the 3:12 in the morning, and this is the right time for the complication. Of course, after this, we are convinced that we were not doing the right thing, but you choose the cherry, now you eat it. So this is the fact. Back to the future, nowadays, we have different catheters, we have different solutions. This is distal part. Let's see, this is the navigation of new, latest, let's say, 5 French catheter. Bring in pericallosal artery over the Chikai 14 black guide wire. The catheter is blocked. Why it's blocked, we'll speak about later. And now this is the solution just after the thromboaspiration from the syringe of 10 milliliters. So I'm aspirating from 10 milliliter syringe, and this is the the solution of the occlusion, but I have not been on a contact with the clot. I was proximally to the clot. So what happened? Why I couldn't go further? Because the catheter was too big, so it could not get into the pericallosal secondary, or it was because of the gap in between of the guide wire and the catheter to enter the bifurcation. So razor effect. As we are moving towards the angles or over the side branches, of course, razor effect will be more present. And of course, it will be more difficult to bring the catheter in a distal side. So the anatomy will for sure influence the fact that we can bring the catheter in a contact with the clot. So what is the correct, one more thing, correct aspiration pressure? If I showed you the aspiration of the 60 milliliter and then I'm using here 10 milliliter syringe, what would be the appropriate pressure just because the vessel collapse? These catheters, we can bring them distally, but it can make a problem. It can collapse the vessel. So if you can choose the right catheter and if you can choose the pressure volume, which one will be the right pressure for the catheter? 043, 046, or 62, will they be the same? If you can choose it on the pump, which value will be the right value for your pressure? The ratio between outer diameter and the treacle vessel will influence of the aspiration power or possible collapsing of the vessel. Friction of the clot will influence on what you're doing, raising up the risk of the breaking. These are just some doubts. Let's get back. 2017, NH1, the patient got distal migration, and this is the A3 segment in a cerebral anterior artery, but it's on a both side, and NH is 1. So there was a doubting what to do, treat or not treat. In that moment, I had just embotrap. And you see, this is the embotrap distally. Why was the idea to use the embotrap distally? Because it has a lower radial force. I choose the short catheter, so get the lower friction of the stent retriever. One pass on the other side, and this is the result. If we do even talk about the distal segments, there's still different situation, like in this is the distal migration on a T catheter, and we have the occlusion of the callosum margin. So microcatheter deployment, positioning the small catch-mini, this is the short one. Why? Because if I'm going distally, I don't want to use the long stent retriever because I'm going to have more friction and I potentially can hurt more vessel. So this is one pass. I have still the clot distally, so I'm going to repeat one more the treatment with the catch mini distally. This is the short one, 10 millimeters, and this is how it looks just after 2 passes. But these vessels are still the straight one. If we're speaking about the inferior branch, or let's say dominant branch of the MCA, it's a large vessel, it is distal. Okay, let's take a look here. What's happening with nowadays catheter? You could just dream to bring jet D so distally. Now it's possible. Okay, it's done. But risk of navigation and treating this vessel, this up here parietal branch, Rolanding branch, or fronto-opercular branch are completely different in M2 and even in M3 segment. If we speak about the temporal anterior arteries, even higher. So I see this way increasing the risk. Why? From the back till the front part, as the vessel is smaller, passing the shorter period inside the insula and much more tortuous. These are the high-risk treatment group candelabra. So the vessels are smaller, more tortuous, and more side branches. We have the responsible one for NIH. So it means it's very easy on a straight segment, but in a curves, it start to be tough and interesting. So how can we bring this to this? As we go, it would not be easy to identify the occluded branch, especially if the vessel is occluded from the origin and if you cannot identify the clot on unsubtracted angiography. Is it occluded or is it side branch? Looks like it's occluded. Okay, let's get there. This was the initially, and I've been treating it with the Nimbus small stent retriever, but does not have any radial force. It's just like picking up the clot. And this is the result after the first pass. So we are using nowadays minis for distals with less or no radial force. Just we were speaking about before the Tiger 13, which is fantastic tool. So to obtain less friction on the vessel wall. But is the same length of the clot at initial, if you have the clot ab initio, or if you have a distal occlusion as a secondary migration? We should think about also that. And those two kinds of clots will be a little bit different. We cannot know what is anatomy after the occlusion. And just like in this case, I've been doing it recanalizing, getting a small microcatheter. This is the 15 because I've been thinking in M2 segment, I'm going to use a little bit longer catch mini and see what's happening here. This is the vessel that I've been treating. So the vessel is very, very tiny. Yes, it's superior. It's not dominant branch, but risk here and the treatment of this vessel is much, much higher. This we can discover just after the treatment. And this is the final angio. As we were speaking before, ICAD and presence of the atherosclerotic disease is a big mess, and it makes even proximally more difficult to treat. In this situation that we have smaller diameter of the catheters, we can see also the stenosis of A1 segment. The risk of the treatment at A1, A2, or these M2 segments will be different. For sure, will be also higher than more distal segments. And if we take a look here, all these branches are closed. Yes, of course, risk will rise as much as we have to repeat the passes with our guide wire, microcatheter, and stent retrievers. One more doubt what to do in this situation. So we have occlusion of the superior branch and we have occlusion of the distal A3 segment. And what is the distal limit for distals to take in consideration? When is a distal too much distal, till it's not difficult, risky, and after that will become more risky, so that is too much distal? Are the same risks in A2, A3 and its branches with the distal segments of dominant MCA branch against the frontopercular branches P2, P3, SCA, ICA, PICA, which are very high-risk treatments. Risks in distal treatment are different for different branches, and they are determined by the multiple variables. Some of them we cannot predict. To have correct conclusion, we need homogeneous groups with homogeneous variables. Thank you. This is my personal opinion.
Thank you. Thank you. Any comment? I mean, some of the comment that came up is that secondary occlusion is very different than primary occlusion, right?
Yes.
And a lot of the cases you show were secondary occlusion. So now, based on the results of this trial, do we have to project these results to the secondary occlusions or not necessarily? Anybody wants to comment on this? In the
Well,
meantime,
I guess that Well, there are
Max,
two
in the
questions.
meantime, you can prepare your slide while we discuss this.
So
I mean,
what was
are
the
there any
fact?
technical points that can help us?
Yes,
In
yes.
terms of like, it's not so much to go for not to go, that's a different story. But if we're going for them, how can we do this in the best way? I think that remains very important.
Yeah. Can I show my case to answer your question, Max, and comment on Vladimir's?
Yeah, go ahead, please.
Would
Yeah,
that be okay?
Yeah, of course.
Can you guys see this one?
Yep.
So I only have 2 slides. I think there is an issue, at least I'll say I personally don't always recognize accurately, is Vladimir, what you just touched upon is how do we accurately identify these occlusions? So this was a primary. I started as an M2 occlusion. I would call it distal M2. How about that? You can criticize me. And the way we do that, we do an injection, right? We wait for a late phase, hoping that the branch will fill to the point where it's occluded. So that's where I thought my occlusion was. I climbed it quite carefully with the new tools. I used the Socrates 038. And I was like, you know what? I just want to make sure that the occlusion is still there. So that's where the occlusion was originally. So what I did is a very gentle micro run somewhere inside the Socrates 038. So I just took a tiny microcatheter, placed it just proximal to the tip of Socrates. I do a very faint injection. I realized the occlusion is actually way more distal than originally thought. Now you could criticize my technique and you could say you probably pushed the clot forward, which is quite possible. I might have as I was climbing, but that's another issue, is that perhaps we're not careful enough, or I'm not careful enough.
I doubt you pushed it. This is something we deal very often. It's called pseudo-occlusion, right? In the neck, we're very familiar with this, right? You have an occlusion of the cavernous, and you don't see opacification of the cervical ICA because there's a column of blood preventing the contrast to go forward. The same concept applies to every sort of microanatomy. So this makes complete sense. Here you have a column of contrast between the presence of the clot and the proximal bifurcation, and this is how it looks like. So absolutely makes complete sense.
And so here,
one comment. Can you hear me? One comment on that. I agree with both of you. But the one thing I would constrain it to is that the pseudo occlusions occur when you're in the same vessel segment. So Max, what you may be seeing is you're still in the same vessel segment, but just a more distal aspect of that vessel segment where you thought the occlusion was. That's all.
Well, yes, it is the same segment. Now I would argue it's not an M2 occlusion, it's more of an M3 occlusion. Semantics, it doesn't matter. The point is I would argue, had I not advanced the aspiration catheter further and aspirated, it probably would have been a failure. Either the vessel would collapse, we don't really know if it's real or not, or,
because you would have aspirated to proximal, essentially.
Exactly.
Right? Yes.
And I think it's happening way more commonly than we...
This is a very important technical concept. I'm very thankful that you brought it up.
I just want to add one more thing. I assume, Max, that you probably, you had backflow. So that's a good, point to say you did not push the clot probably, because you had backflow before you injected your contrast, right? So I don't think you pushed the clot. I really think that's the phenomena that Eitan was just talking about.
I think unless we look for it meticulously, we're gonna have more of these cases. We've had them, we're just not recognizing. One of the reasons why aspiration fails. And as much as I don't like stent retrievers for distal occlusions, and I always go with aspiration first, with stent retrievers, it's a little bit less of a point because the device grabs so much length. But we need to identify those failures and talk about them more. So that's it. That's my little case.
Fact is thanks for your case. But the fact is I brought, yes, the secondary occlusions, but I wanted to touch the technique. The fact is aspiration, we get fantastic, perfectly navigation catheters for distal aspiration, but what would be the right aspiration power to get the aspiration? What would be the right pressure? And just show you the catheter 3 max, which was the base of the distals, and what happens when the vessel collapse. So the fact is like, yes, I can agree with you about the thromboaspiration with the new catheters using maybe more frequently in the distals. But after the problems seen also with the thromboaspiration, because these catheters can make really powerful thromboaspiration, we have to understand also to use and how to use thromboaspiration distally.
Excellent. Excellent points. I don't know if there was Raj Kamal that wanted to show cases, but I'm not sure if he's connected at this stage. If you are, please just go ahead. Otherwise, Max Shapiro, anything else we wanted to raise?
No, I just want to thank everybody for attending. And I think if anyone, it's been a great discussion. And question, like, obviously raises a lot of questions. I would think we can follow up like this right versus left thing. Maybe it'd be interesting to see a sub-analysis of that. We're looking forward to the distals results. And is there anything else anybody want to say? We did, like, there was a lot of discussion, a lot of points were raised in the chat that we didn't really have time to address because there was so much going on. So I want to thank everybody who commented there, even if you, like, if it didn't get like necessarily brought up. I think it, thanks for participating.
Is Frederic still connected? Yes, I see Frederic. So I would finish up by discussing what's next, right? Where are we going from here? So one option is like to say, okay, the technique improved, so let's just rerun by using better technique, maybe improve the definition, right? Maybe improve the scale. Another thing, like, could it be like, to take a step back and just do like focus only on M2s? Because right now we know how we all agree that M2s are the ones in which like there's so much effect. So can we at least focus on there and prove an effect there? The problem with that is that we may fall into the same trap of like cherry picking, right? So where are we going from here? Well, what do you envision, Frederic, as the next step? And then other people maybe can follow you.
So my opinion is that distal thrombectomy is not dead so far. So we have to wait for the overall analysis of discount first, to wait for distals and to wait for Oriental MIVO, because only 2 trials have been published so far and we have only 1 interim analysis. So first, and if all the other trials are negative, I think there is still some hope. So maybe to have a better patient selection, and maybe to change the tool, because the stent retriever we have are just the same as for proximal occlusion, but with a smaller size. And maybe we have to change the design of the stent retriever, which are not suitable for distal occlusion. So I think we have, as I said, better patient selection and maybe change the tools to recanalize these distal occlusions.
Can I ask you to follow up on what is better patient selection? More proximal lesions or to prevent cherry picking? Like,
I think we should only include MCA occlusion, because most of the distal occlusion we had in all the trials were MCA occlusions. I think we have to include proximal M2 occlusion. We didn't in discount because we thought it was not clinically relevant, but because we saw that proximal M2 was like distal M1. But I think we have to include them. And as I told you, maybe include patients with a higher NIH score, to include only patients with NIH 10 or more.
Okay. Sophia, you raise your hand. You want to?
Yeah, I was wondering if David is on the line. Is there any way to know, like a scientific pharmacological way to know the good dosage of intraarterial lytic to give to the clot that would work? Is there any past studies, bench studies that can guide us? Because we sort of just arbitrarily like use 2 or 4 milligrams of TPA, but maybe the people who can't get T and K for whatever reason, we could give some lytic, in these distal occlusions. And if we knew the right dose based on some mechanism, maybe this is the safest option.
Unfortunately, it's a great question. I think the answer is no. I don't think we can go to the literature from any particular study to look at dosing. And you have so many differences in terms of these variables, in terms of exactly where it's delivered, in what specific setting of vessel occlusion or reperfusion, whether primary or secondary, very, very different. And then between TNK and TPA, very, very different, or other agents, very, very different aspects. So I think the sum of it is that it's empirical. So, I think you use the smallest dose that you think is reasonable to have an effect. How far do you go is an issue that, from an endovascular standpoint, comes up in general. How aggressive are you, in terms of these cases? And that does touch upon this other issue that I don't think we discussed earlier this morning or today regarding the trials that were done. We talked a little bit about the cherry picking and the biases of patients that went in or did not go into the trials, but sort of the intent to treat and how aggressive were we in terms of the numbers of passes and how is that standardized? I think there's biases there as well. So the simple answer is we don't have any information concretely on dosing of lytics, and I would say no, we cannot go to trials to say that definitively we do.
And what do you envision as the next step? Let's take aside a little, let's just look at the current thing based on what we know so far. What do you think would be the easiest next step?
For who? Who are you asking?
You, David.
There's no question that we have questions. We have raised more questions than we had before. This has been a list of questions. And I see that Shadi just commented. I think we have to be careful rather than asking do we have questions? We have a million questions. I would actually argue and be devil's advocate that we didn't answer these questions appropriately. We've just uncovered more questions. I think we have to be very careful in terms of how we approach it in terms of the methodology. I think when we look at Oriental Mevo, Devo, God knows what's going to happen. A very important point is access to data, patient level data, the definitions that were used. And as I've pointed out, and you'll see in the literature coming up, even in New England Journal published studies, the methodology, the definitions, the imaging, the angiographic definitions are not only not made available, the data are not made available, and we don't know what to do in clinical practice. So, Shadi, your point is go after proximal M2 and I6 or more.
We'll have him talk after you.
All right. All right. But all right, I'll take a jump start on that. I would not go in that direction. It depends on who wants to do that study. I think you have to do it with a proper methodology. Just recognize that you are, if you do or do not do it correctly with a proper methodology, you are taking a bite out of an existing market and patient population that can benefit potentially. And you have to ask yourself, are you really willing to do that? I've asked a number of interventionalists and stroke neurologists whether they would be willing to be randomized with a proximal M2, whether you want to call it dominant or non-dominant.
David, I just want to clarify. I meant go for it. Go for EVT.
So clinically, you meant
yeah. If someone has a proximal M2 stroke scale 6 or more, I think we have data from the earlier EVT trials to go for it. Take this patient for thrombectomy. More distal occlusions, proximal M2 with a 0 to 5 stroke scale. I think these patients, we need better patient selection and better EVT tools.
Okay, but I can argue against what you're saying, Shadi, because the patient you just described, he was included in Escape Mevo, right?
Yeah, I think the issue is Escape Mevo also included patients who have 3 to 5, stroke scales. So and not all of them were proximal M2s, and again, many people brought up the issue of cherry picking. So I think and if someone has the proximal M2 and based on the initial EVT trials, they were included, if they had a stroke scale of 6 or more, I would take this patient to thrombectomy. If we have a more distal occlusion, then I think this is where I think we have to think about more trials.
Okay, how about the ACA and the PCA? We didn't talk a lot about those because those were not overrepresented in these trials and so forth. But what's your stroke neurologist, vascular neurologist evidence based on an A2? Like A2 can be pretty symptomatic, right? So what's
I think we need better tools as well. It's a smaller artery, and I think we just need better tools. We need to come back and try to conquer these lesions with better tools.
So as of today, an A2, you would not ask?
I would not treat it with aspiration or a stent retriever. I don't think we have evidence that it works. I think proximal M2s, there's some evidence from the initial EVT trials. These patients were included. More distal occlusions. At this point, I would continue not to take them to thrombectomy until we have better tools.
I agree and disagree, Shadi. I would say that it depends on what the severity of the stroke, the NIH stroke score deficit is. I mean, this is the same as we use with lytic. It depends on the severity of the deficit, not based on vessel segment necessarily. But then when you consider how are you going to treat it, yes, then you have to think about what the best approach is, and I don't think we know.
Interesting, because they feel that the thrombectomy from the ACA is easier than from the distal M3, kind of, for me.
That's what probably Vladimir wanted to say.
Guys, I just wanted to say that.
Well, then we should do a trial. Then we should do a trial.
But how easy it is to do a trial?
No, I think I think many people would be comfortable randomizing an A1 or an A2 or a P1, and they wouldn't be comfortable randomizing a proximal M2 with a stroke scale of 6 or more. Yeah, I mean, we don't treat A1s and A2s, and I think our center would be very comfortable randomizing this patient in a trial. I think we need trials, and I think, I remember Mayank said it when he was doing Escape. Initially, he said, if my family member comes to the ER with an M1 occlusion, and, I wouldn't treat them outside the trial, I would put them in the trial. I think we need to have this mentality when we come back to do, more MEVO and DEVO trials.
Right, but Shadi, but not for. I think everybody's in agreement that the one subset of all these distal vessel occlusions that everybody has disagreement on is the question about the M2s and how they're defined. Everything else, yes, it's every lesion is a little different, and we need more data.
Honestly, I think a lot of us here we disagree on the ACA and A2 and P1 proximal P2. I think a lot of us here may disagree on this view. Like a lot of us, I think I speak for myself, but I know Max as well. He, my partner. Like an A2 is with a significant clinical presentation is hard to deny a thrombectomy because we know how
based on what evidence. Is there any evidence to support it?
But maybe we have to wait the meta-analysis on individual data.
The evidence, I think to convince people that this is the standard of care, you need to include these patients in an RCT.
But maybe we have to wait the meta-analysis on individual data and the subgroup analysis to see if there is a trend for a good outcome in patients treated by thrombectomy for PCA occlusion or AC occlusion. Because if there is no trend, I think it's useless to build a randomized trial because it's a very small amount of patients. So it will be
hard to make a trial out of it, right?
Yeah, of course.
But there will be circumstances in which people, like somebody's not eligible for TNK or something like this. Like we had a patient that was recently post-operative from a cardiac surgery, like an embolic event, very likely. So there will be times when we will be one reason or another we're going to be going for these lesions.
I'm afraid it's such a heterogeneous group of patients. We want evidence, I get it, but do we really believe that there's going to be evidence-based where it says A2 should be always recanalized or A2 should not be recanalized. Not every A2 is the same. Sometimes you see aphasia, and sometimes you see motor deficits and an IH of 10 with an A2, right? And your next patient is an IH of 1. Applying the same rule, it's either always recanalize or always do not touch them, is not the right decision for this. That's how we got into the
Maybe
first place.
I agree. I would I would uncharacteristically agree with Max and say that you're right. But the bigger question, Eitan, who's going to pay for your damn trial? If you want a trial done with proper methodology, name the sponsor, name the device manufacturer, or are you going to pay for it yourself? And from a very practical standpoint, I think the answer is we know it's not going to get done or not done properly.
And maybe you should, if you want to include these, maybe just target NIH 10 or more. Maybe that's the more likely group that's not going to do well with medical treatment, and maybe target these patients like the basilar trials did.
Going back to this, to one question for you, Shadi, and David and the vascular neurologist online. Like, do you have, like, in your practice, right, would you be more willing to ask for a thrombectomy if you cannot give TPA? Like, based on this result, we're talking about distals, right? Let's say it's 5 hours from the onset. What other alternative you have, right? You don't care and you just, use the results of the trial to say there's no evidence, or those are specific situations where indeed you're going to ask Mahesh, please go and open this vessel?
Yeah, it depends. It depends on the details. The significance. I think it's a jump to say, whether we're considering alternative therapies, lytics, novel antithrombotic approaches. We just don't know. As I said earlier, everybody is salivating over the distal trials recently. Everybody that has a different approach. So, baby pharma, novel devices, novel aspiration approaches. Everybody is drooling over this because they see it as a juicy target now to go after. Do we know? No, we don't know what's right. We have no idea.
Yeah, I second what David said.
I mean, the part of the issue is, as David mentioned earlier, now that we have the situation where I think medical legally there is an issue. Our patient's going to be denied treatment that I think a lot of people would think is important to give. We have to be very careful. And I agree. There's such a heterogeneous group. We just want to how to best preserve the ability to do this when we have to do this. That's one question.
I think there's a key learning point that comes up in endovascular therapy. So this is the second topic of potential indication expansion for thrombectomy that's come up in recent years. First was large core, right? And now distal. We have not all the data in, but some data. And there's a very surprising result of the trials. Very high, well done trials published in very top level journals with a lot of data. And rather than universally expanding the indications, we wind up short of that, where there's a million questions about, in this case versus that case, how do we consider this variable versus that variable? And Maxime, I agree with you completely. It leaves for a lot of questions that simplistic statements are not going to defend or justify. So, I do or do not do distal thrombectomy. I don't think that that's true. That can be true one moment and not true the next. It depends on each case. So I think in general, there's an interesting theme that's developed that rather than just going for indication expansion, and some of our colleagues, as you know very well, have suggested, don't worry. Stroke, STEP is now going to answer this question. I'll be the first to say and record this that I've said a long time ago. No, it will not. It will not answer this. We are never going to get to the answers in some of these questions. And you're going to have to go by a combination of variables on an individual case basis. So the hope for broad indication expansion, this is wave 2 of a topic that came across that is not just a pure green light,
I think it's the perennial problem of the trials run ahead of the technology. So we don't really have a stable, as you're evolving the technology to do these more aggressive maneuvers, you prematurely get into a trial, and then it muddies the water. It happens repetitively.
Vladimir?
Sorry, guys. I have to run into Anjo because I have lady 30 years P2 occlusion.
Okay.
But the better question is, what device or technique are you going to use?
Do you want sincere answer, my friend?
All right.
Oh, it's gonna yes. I'm gonna use catch meaning.
Okay. All right.
I'm running.
Bye.
Thanks for everything, guys.
Anyone else wants to make comments? We're toward the finishing up here, but we have a lot of people still connected. Anyone else wants to make a comment or like a question? Like we have a couple of minutes more. Otherwise, Max, you wanna?
Somebody else just came in. No, thank you everybody. A lot of our faculty, already, had to go, and just thanks everyone for coming. We'll have this recorded. It'll be available, and hopefully we'll continue. The discussion will continue. Thank you.
All right. Have a good rest of the weekend. Bye-bye.
Bye-bye. Ciao.
Thank you, everyone.
Bye-bye.